I'm a senior in the Women's and Gender Studies BA/MA program. I am on the board for Triota, which is the WGS Honor Society at DePaul. I think that's all my titles. But yeah, I'm super happy to be here, and a big thank you to all of the panelists for joining us today.
Yes, so that brings me into, I would just love to extend some thank yous and acknowledgements today. An obvious thank you to our panel for making time to be here. A big thank you to the WGS Colloquium and Triota for really help organize and do a lot of the heavy lifting with this event. Logan, of course. A big thank you to the Women's Center, to Nina Wilson and the Alumni Network. A big thank you to the WGS department as a whole, and would love to shout out our two facilitating faculty. So Dr. Mukherjee, who's here with us today, thank you so much. And Dr. Russo, whose birthday it is. And so she is taking the day, but she was really sad that she could not be here. And just an FYI for everyone, the event is recorded for accessibility purposes. So just for your information. Before we go ahead and transition over to our panelists and learn a little about them and get started, I would love to just share and center our Women's Center values. So just bear with me for one moment. Let's see, will it work? Is it? Okay, excellent. So yes, these are our Women's Center values. They're sort of abbreviated, but those of us who frequent the Women's Center, our staff members, folks in WGS, we really try to embody these several values in every space that we walk into, and I'm definitely wanting to uplift them here today. So the first being respect for people's gender identity and pronouns, the second being active listening, the third being mindful of and accountable for the impact of our words and our actions, regardless of intention. The fourth being supporting and caring for ourselves and others. And the last being open to learning from others, which I think we will be doing a lot today. So without further ado, I would love to open it up for our panelists to do some brief introduction so we can get to know you a little bit before we dive into questions. And I will just leave it open, no particular order, whoever would like to just jump in.
I'll go. Hi, everybody. I'm Missy Furlette-Koshi. I am a DePaul alum. So I graduated with a degree in Women's and Gender Studies and a minor in LGBTQ Studies and Community Service Studies in 2009. And then I went on to become a certified nurse midwife. So it took me a little while to get all of my prerequisites done for nursing school, since I focused on getting a BA at DePaul. But I ended up attending University of Illinois at Chicago. And for the last 3.5 years, I've worked in a private practice in Oak Park called West Suburban Midwife Associates. And we provide full scope care to folks with a uterus. And so we deliver out of West Suburban Hospital, which is, we essentially can, it's one of the only practices that's midwife owned and woman owned. And it's also sort of, we're not, we have privileges at our hospital, but aren't governed by our hospital, which means that we can practice really independently. And also full scope means that we do, reproductive health care. We don't do abortion care, but we refer folks to abortion care. And then we take care of pregnant people and do well care for people. So it's across the lifespan, not just baby catching, even though that's a lot of what I do. What else? I'm a mom to twins. That's kind of at the forefront of my life. I have 15-month-old twins, Jessa and Joel. And I think that's about it.
Thank you.
Hello, everyone. I'm Karie Stewart. So glad to be here. I am a certified nurse midwife. I am the director of midwifery at the University of Chicago.
Yeah, you
are. Which I just took that appointment the beginning of this year. Also a classmate of the dear Missy here. So we go way back. I graduated from UIC as well with my master's in nursing. And so I am also a certified nurse midwife, practicing full scope, predominantly to Black and Brown patients on the South Side of Chicago, which is currently experiencing a maternal health desert situation. So I do lots of things. In addition to full scope practice catching babies, I also do some advocacy for midwifery, specifically for melanated midwives. You might have heard of my organization, Melanated Midwives, where I am advocating and supporting and hoping to provide financial assistance to student midwives across the United States, and helping them finish their studies and pay for their exams and get out here and do this work that we are doing right now. There are not a lot of melanated midwives, and we need to have more. And so that's why I started this organization. In addition to that, I'm doing a little bit of research and community-based interventions through melanated midwives. So there'll be some more of that. And I'm excited to be here. I am a single mom of a 19-year-old who is in college doing his own thing. And so excited about his journey and future. And that's what's going on.
Well, thank you. It's so wonderful to hear from both of you. I will just double check, is Hannah Cutts in the Zoom currently? I know she did say that she was going to be a couple of minutes late, so just double checking. Okay, not here yet. I think I will just go ahead and read her bio to get her kicked off here. So Hannah Cutts uses she, her pronouns and is a nurse midwife working in 2 clinics on the south and west sides of Chicago. Oh, never mind. She just got here. Hold on one second. Hello, Hannah.
Hi.
Sorry. Thank you. Sorry to put you on the spot. We are doing bios right now, and it is your turn. I don't know if you need a second to get settled in, that's totally fine.
No, thank you so much. I'm so sorry for being late. Friday afternoon traffic. I'm Hannah, she, her pronouns, and I'm a nurse midwife. I work at a couple different clinics on the south and west side of Chicago. And what else should I introduce myself with?
Anything you want, Hannah. Everyone was just saying a little bit about like where they went to school and sort of like what advocacy work they might have done or are doing, but no worries, whatever feels good to you.
Cool. Yeah, I went to nursing school in Connecticut at the Yale School of Nursing, and went right through to get my midwifery degree because I knew that's what I wanted to be doing. And before I went to midwifery school, I worked in education and public health, and I worked as sort of like a community social worker, and all of that definitely sort of brought me into this world and the world of reproductive justice.
Well, excellent. Thank you so much, Hannah. Sorry to put you on the spot there. I think we can go ahead and just transition. I think introductions go really well with our first question of the evening. So the first question being, what did your career paths look like? How did you end up where you are right now? And I think we can just popcorn, whoever feels most comfortable going first, whatever.
Sure, I'll go ahead. A little different transition from what I originally thought. So I originally got into public health. I had, I had my son when I was married to his father, got a divorce, things didn't go well. And so I ended up going back to school. So I was an older adult and trying to find my career path and which way I wanted to go. I always thought I wanted to be an OB-GYN. But having my son, I realized how much time commitment that would take. And so it just was not feasible for my ideal to be a more involved parent. And so I had transitioned and went back to school at Southern Illinois University in Carbondale. And so when I did that, they had family housing. So it was just an ideal situation for myself and my son, so he could go to school and then I could go to school too. So we did that, stayed down there for 4 years, got my bachelor's in biological sciences, and then I transitioned into public health where I got my master's in community education. And it was at that point that I realized that just being in public health, I wanted to do more. I wanted to care for patients a little bit more extensive than I was just doing education. And so I found out about a midwife the second time around, because I had a midwife for my son when I was pregnant. And so I loved the care that I got, very individualized, personable, and the practice they had was in an old home, and it felt homey. And so it was just very welcoming. And it wasn't nervous being a first-time mom for me at that point when getting care. So I knew at that point that I was like, let me just do that. So I applied to the program at UIC, born and raised in Chicago. So it was just ideal for me to come back home and have support from my family. And I did that. And I actually did my internship for my master's of public health at the University of Chicago. So to transfer back and come back, it's been exciting to be on the other side, is now being on staff. But what I learned when I got here to do my midwifery, it was rough. I took the NCLEX 4 times. And so I'm not a good test taker. And so, but I was determined because I'm a nurse now. So I figured it out. And I wanted to have a little bit more hands-on experience on labor and delivery. So I took my first job working as a bedside nurse at Mount Sinai on the west side of Chicago. And as we all know, Mount Sinai is trauma. It's a trauma hospital. And so a lot of things happen and come through that door. And so I gained a lot of experience through there. And so it really helped me prepare me to care for the patient population that I work for now. And so once I did that, I was doing that while I was working. I worked while I was in school, as Missy will tell you. I had a lot of hats, but it's how I function. And so learned that, got through midwifery. Midwifery was a little bit of a struggle just because there's not many students that look like me. But I had a supportive cohort and some other staff members. But it was a journey, and especially when you're trying to raise your son in the city by yourself, it was hard. But I was determined. And so I did that. And even when graduating, there were some trials, just getting the amount of births that I needed. I just couldn't pull it off. And not because I wasn't working hard and wasn't there. It's just the luck of the draw when it comes to getting the numbers that you needed to do. So I think I only got like 23 births. And then my first job, as you're transitioning, you're like, oh, they're looking for me to diagnose and treat. And it's like, I'm the provider, it's me. And so when you're having that first year, you have those ups and downs and trying to figure out, get to your confidence level, get to your skills up to the point that you're comfortable enough to feel like you can really do this. And so in the midst of doing that, I did that in Southern Illinois. And so what happened was when I graduated, there wasn't any positions at the time in Chicago that I really wanted to take. There were some clinic positions, but they didn't allow me to do deliveries. And I didn't want to lose my skills delivering, because I really also only had 23 deliveries, and then to not practice catching and then be set back, I just didn't want to take that risk. So there was a job opening 6 hours away back in Southern Illinois where I went to school. And so I had to make the hard decision to uproot my son again, to go back down there with him to do this job, or to stay here and just hope that I would eventually find something. I took the job, but I didn't take him. He stayed here. He was a junior in high school. And so, we had a discussion about him staying and being a big boy and going to school and doing his thing, and he did. He took himself to school and he fixed himself dinner and did all those things. And the only way I took the job was I had to be able to go down to Carbondale on Sunday night, and then I had to be back every Friday night to be with my son over the weekend. And so they agreed to that. And so that's how I took that position. I did that for an entire year. And so when the University of Chicago had an opening, I jumped on it. So, and they say once you get that first year experience, you can pretty much go anywhere. And that really did happen for me in that way. So working in Southern Illinois was a rural area, totally different from the city. But the population acuity is pretty much the same, you know, the same conditions, experiences as far as patient population and the social determinants that they experience are pretty much the same. It's just a predominantly white poor population, as opposed to the population I serve is more Black and brown. So I learned a lot of things, and the difference there from here, that we didn't have any residents. There were attendings, but the practice that I joined, everyone pretty much rotated through the schedule. So if a patient came in for the practice, I managed that patient. So a lot of high-risk situations that I didn't necessarily get too much learning on my own in school, I got it. And it was a lot of hands-on, just kind of throwing you out there, and there it is, you figure it out. So I got a lot of my experience from that, and feel like I was pretty solid. I went from 23 births in school to over 100 that first year that I went to Southern Illinois. So I think I'm good. I think I was good when I came back home and was ready to go. So, so I came back to the University of Chicago, and then worked there for about a year and a half. And then the opportunity became open this past year for a new director. And mind you guys, I have only been out of school for about 3.5 years. So to be out only 3.5 years and then to be offered a director position, that wasn't in my plan. But nonetheless, I was excited about it. And, you know, as much as leadership can be challenging, I felt like myself being a Black woman should be representative of the population in the midwifery department on the South Side of Chicago. A lot of patients don't see us in those positions. And so very happy to be where I'm at. Allows me a platform to highlight some of the things that we need, we desire. And so that's how my journey has been thus far.
Thank you so much. Would anyone else like to jump in?
Should we do more intros, or is that what or like more journey things, or do people want to ask questions? I don't know what we're doing.
Yeah, so the first question, we're going to be doing like a lead discussion, and then we'll be opening it up for questions, hopefully, if we have some time at the end. So the first question is, what did your career path look like, and how did you end up doing what you're doing now?
Cool. Yeah, I'll go. So my career, most midwives I know don't have a straight and narrow path to midwifery. It's, they either have a baby and fall in love with their midwife, or have a baby and have a terrible birth experience, or discover somewhere along the way in their life that they think midwife, like they're interested in birth and they want to kind of get their feet wet and eventually become a midwife. So like, it's not, for me, it wasn't exactly linear, but I actually found out about midwives, or gained a better understanding when I was at DePaul. So I took a class called Voluntary Motherhood, and it was about birth it was about reproductive health care and birth, and it traced the history of sort of women's healthcare from the mid 19th century on. And so it gave like 150-year sort of snapshot about like how birth was in the home, and then it moved into a hospital, and then there was a new resurgence of people doing out of hospital birth again. And it was taught by Ron Graff, who is a family nurse practitioner, but he was married to a nurse midwife, Linda Graff. And so I didn't know that at the time, but I came to know Ron and Linda later. So I did a project on doulas. And after I did a project on doulas, I became a doula. And then after I attended a couple of births as a doula, I discovered that I didn't want to just kind of support people and do, doulas do educational, physical, and emotional support, but they don't do any medical care. And I realized after attending a couple of deliveries, one of which I remember pretty vividly at St. Mary's Hospital on the West Side, like, oh, I want to be catching, like, I want that job. And so, it was really hard for me. I was always very into like, like reading and social sciences. I was never a big, like, kind of hard science, chemistry, bio kind of person. And so attaining all the prerequisites you need for nursing school, because for all of us that are on, all the panelists, we're certified nurse midwives, which means that we are nurses first and then have a master's or a doctorate and are nurse practitioners. And so it was really hard for me to get into nursing school. It took a long time to get my prereqs done. I had to do like anatomy and physiology and human growth and development and organic chemistry, inorganic chemistry. And I took a couple of these classes a couple different times because after I tried to do a couple of them while I was at DePaul, and I was, 22 and didn't know that like I didn't have to spend a whole lot of money on tuition. I could do it at a community or city college. I sort of thought that I had to do it at a university, which wasted a lot of money. But either way, I started acquiring these like 6 to 8 classes that I needed. And it took me about 3.5 years from the time I finished at DePaul till the time I was admitted into a midwifery program. And I applied to UIC 3 different times. The first time I was denied. The second time I was waitlisted, and then the third time I got in. And I think that the hardest part about admission is that I had to try to convince nurses that I would be a good nurse. And the thing is I never was, nor will I ever really be a good nurse. Like that was not the end game for me, but it's what you have to do to become a certified nurse midwife. So it was a really after I had graduated from DePaul, I moved home to Michigan for a while, and I tried to get into University of Michigan. I tried to get into Wayne State University. I tried to get into Madonna University. I tried a bunch of different paths. Like, okay, should I just get another bachelor's and then go on to do a master's program? But UIC's program is a direct entry. So you do your nursing portion in an accelerated manner, and then you're directly admitted into your master's. And so eventually UIC let me in, but it was really hard because I was working as a doula, I was working as a nanny, I had no money, and people kept asking me like, well, maybe this birth thing is just like a hobby for you. Like maybe this isn't actually your true calling. But the thing is like, if you do birth work and you're willing to get out of your bed and go serve people in this incredibly vulnerable moment of their lives, you're called to do it. You wouldn't do it otherwise because it's just too hard. It's very disruptive work. It's beautiful, joyful, wonderful, awesome work and hard, but it's really disruptive. And so I kept chugging along, and I finally got into UIC. Like Karie, I'm not a very good test taker, so I had to get over a lot of anxiety. I'm great at writing papers. Beth could attest to that, as she was my advisor at some point. I can explain anything, but testing was not my thing. And so, it took a lot of conditioning to get me through nursing school and through graduate school. But I did it, and I did work as a labor and delivery and postpartum nurse while I was in school. Briefly, I did it for about a year. And unfortunately, my dad passed away unexpectedly, and I was not allowed by my nurse manager to switch from working nights to days and then switch from working full-time to part-time. And so because of that, I was like, all right, well, I can't do this and finish school and figure out my life. So I ended up getting a graduate assistantship because a former faculty member of DePaul, Dr. Natalie Bennett, was the assistant director of the Gender and Women's Studies program at UIC. And so she hired me, and she and Jenny Breyer. And so I ended up sort of filling up my feminist cup on the east side of campus, and then promptly getting it deleted and squashed upon on the medical campus. And then I would fill up my cup, and then it would empty out again. And so I don't know, I've never belonged very well in the medical hierarchy, but I think that midwives are people who can bring a feminist framework to healthcare in a way that's sort of unparalleled to any other position, because my whole goal as a provider is to meet people where they are and help facilitate whatever it is that they want to do. And that's unique because that's not the way like top-down hierarchical medical education works, which is also why I didn't fit in nursing school very well. And I pissed off a lot of faculty members because I'd be like, this doesn't make any sense. This power dynamic doesn't make sense. What are you doing with your life? From their point of view, they were probably like, I'm just trying to teach you nursing. Like, shut up, Missy. But I'm like, no, this is not right. So Karie knows. Karie was my classmate. I was not quiet. I never was, never will be. But anyway, all that is to say that I ended up graduating, and I thought that I was going to work at UIC, but they didn't have any positions open. And so I ended up getting my job at West Suburban Midwife Associates right out of school as a new grad. It is a challenging job because we get a lot of people from all over the place that really want autonomy in their birthing choices, which is awesome, but at the same time, don't trust the medical establishment. So even if we have a lot of things like, this gets into kind of the nitty gritty of birth work, but like we at our hospital do what's called intermittent auscultation. So that means that we listen with a handheld Doppler instead of having people hooked up to a continuous monitor. Like this is not something that is true for most places. Most people have people on continuous monitoring. And so people come and they want those things, which is great, but then they tend to push the envelope, and there's a lot of entitlement, almost all of my patients are insured, which is a privilege, obviously. And I would say about 70% of my patients are white, about 65, and then 30 would be women of color, women and people of color. We do have some trans patients, which I've enjoyed taking care of and kind of bringing back pronouns to some of my colleagues who are not well versed in how to care for gender nonconforming people or trans folks appropriately. So the thing that I love about my job is that I am in an independent midwife owned, like woman owned business, which is not something that you come by often. I am in a small practice. There's only 5 of us, 4 of us are catching babies, and we only have 1 collaborating physician. So what that means is that we call the shots on most of the care. And if we need her for a forceps delivery, a vacuum delivery, or a C-section, she comes in and we consult with her, but we really practice sort of by ourselves. And that's really nice because nobody's looking over our shoulder telling us what to do. But at the same time, as a new grad, I had to hit the ground running and figure out how to practice. So I am now in charge of students at my practice. So that's something that I love. I help organize the students and I teach. So I help other people learn how to catch babies now. And yeah, we had a lot of turnover in 2020 with the pandemic. So we lost 2 midwives, which was half our practice, and gained 2 more. And it's been a lot of transitions, and I had my own babies, which is also a lot. And I went through infertility, I went through IVF. I ended up having 1 vaginal delivery and 1 C-section in the same day, because my daughter decided she was going to come out the right way, and my son decided that he was going to hang on. So either way, it's like it's enriched. I share it because it's enriched my life as a provider, because I've literally done everything to have babies, and so it helps me care for other people. But it's been wild, frankly. So I think that sums it up for me for now.
Well, I can talk a little bit about my path, and I so appreciate what you said, Missy, that midwives rarely go on this path in a straight and narrow way. I certainly didn't. If you'd asked me whether I would ever have been a healthcare provider, I would have said absolutely not, no interest in that. I have some healthcare providers in my family, and I saw what that looked like and what the system sort of looked like, and I had no interest. But I think my journey actually started in undergrad, where I studied political science and African studies, just like super useful majors. And I studied abroad in Uganda, East Africa, and studied childbirth, particularly in maternal health, and got to witness some births being done in birth centers in Uganda, mostly rural Uganda, some hospital births as well. And just at the same time as I was like living in a round hut by myself, reading Ina May Gaskin's Spiritual Midwifery, like the old version where she uses the word stoned in the medical way, sort of had my eyes open in a lot of ways. And then more importantly, came back and felt that I had like learned a lot about what poverty looked like and what access to healthcare looked like, and then realized, hello, this exists, of course, in the United States as well, in my own backyard, and felt like I needed to be part of some of that work, and it still took me about like 5 or 7 years to think that midwifery was the way to do that. But I did a lot of education work. I love working with teenagers, particularly. I became a doula for a community doula organization, formerly the Ounce of Prevention, now they're called Early Start. And I worked with a lot of new moms, teen parents here in Chicago. And similar, I think it sounds like to Missy, felt like the doula role was so special and so important and so not enough to be really impacting change in the way that people experience birth. So decided to go back to school, which again, another thing that I would have never said I could do. School's not my thing. And but so I went back to the fastest way that I could. The Yale School of Nursing doesn't require prerequisites. It's the only nursing school that doesn't, that I know of. So I didn't need prerequisites to get in. I think that's a very mixed bag in retrospect. Would I do it again? I don't think so. Yale comes with everything that you might imagine about it. Very patriarchal, very racist entity. And the program is super intense. So, but I did graduate eventually, and came back to Chicago where my partner was, had a baby, finished school, and then started my first job here in Chicago. And I find I chose to be outpatient only. I work for a federally qualified health center, one of the largest FQHCs in Chicago. And because I knew that the education piece is what I'm good at and that I care about, and the hands-on skills. I think maybe I also only had about 23 births in school, Karie. And didn't feel like I was going to be the right provider for people immediately. But I know that I can talk to people about sex and about birth control and about their choices and about their bodies. And I super enjoy that. So outpatient feels really good and feels really informed by my experiences working for the YMCA and working in kindergarten classrooms and for the Ounce of Prevention. And now that I am part of yet another system that is top down and very medicalized and has very little, I have very little control over what the birth outcomes of my patients once they get into the birth situation. I'm just remembering how flawed well, not just remembering, but our medical system is really flawed. I don't know if you all knew that already. But I've been working now for just a little more than a year. I started about 7 weeks before COVID shut everything down. So I know you have some questions about COVID coming as well, but yeah, I'm still very new, still very much learning, and yeah, I think that's it.
Thank you all for sharing like your journeys. I think that there's a lot of power in like our stories and our own personal narratives. So we really appreciate hearing from all of you. I do find it interesting how a lot of us started as doulas. I was a doula, and that pushed me to go back to school because I was kind of butting heads with like the capitalist sort of, you know, for-profit that you kind of have to be in order to pay your bills, in order to do all these things when you're parenting and have all these responsibilities. So I am not going to be a midwife. I want to go into public policy, but there are other ways to fight the oppressive medical system for all of everybody listening. I just wanted to throw that out there. So for our next question, wanted to ask, what's like the biggest challenge you faced while advocating for reproductive justice, speaking of the medical system? And what is something that you wish people understood about either your line of work in RJ or like reproductive justice in general? Also, apologize for my children yelling in the background.
I'll go ahead. I think the biggest challenge for me working in the hospital and my clinics are based in an academic setting, is, and as I, take on this leadership role is really, I feel like there's a fine line between keeping my job and fighting for what's right. And so it's very difficult in this day and age and all the things we are experiencing and seeing, and COVID has highlighted some of those disparities even more so on the south side of Chicago. And so sometimes I wake up and I say, I really don't care. It is what it is, and you're wrong, and this has to be said, and something has to be done. And then I realize I got to pay the bills and feed my kid. And so I have to, figure out that I need to choose my words wisely, because there are a lot of people above me who make a lot of more money than me, can make sure that I don't have a job. And so, it's always a challenge. And even just learning when, being a nurse, advocating for your patient, I feel like I've, as a Black woman, I've always had that challenge. And it's like, I'm always on, you're always, there's not a point where you can't walk in a room and you can't just relax unless I'm at home. And so that has been a challenge for me, but knowing that there are services that my patients are asking for, that they deserve, that they desire. And at the end of the day, I can still advocate for them, support for them, educate them, and, get things done, not only for my patients, but for midwifery as a whole, in the role that I have, and still take care of my kid and keep a roof over my head.
I can go. I'm going to skip to the second part of the question, something that I wish people understood. And I think I'm sort of tailing off of what Logan said, that basically there are so many ways to approach reproductive justice, and it's certainly not necessarily or maybe at all what happens within a clinic or within an exam room. It's anti-racism, it's anti-establishment, anti-capitalism. It's all this work that we all care about to take care of people, and it's not simply about somebody's uterus. It's the whole person, and when we are only considering the medical side of caring for people, we're really missing out on so much more of their social environment. And for me, at least, that's reproductive justice, is thinking about everything else that shapes a person and informs their decisions and allows them to access or not access care and information.
Hi guys, this is Jessa. She came to join us. I think, I know. Here, Mama's gonna say it. I'm still, hi baby. I'm still recovering from the Trump administration and what that's done to people's, access to care, psyche, etc. And so I think that that's something that was at the forefront of my mind, just in terms of where people were and where, I think about like COVID and the response to COVID, and like, we'll talk about that in a bit, but like I don't know, being a healthcare provider in a pandemic is very challenging. And I think that I still wish that people understood at base who midwives are, because people don't know. I mean, when you say midwife and you aren't familiar with what we do, they think that we're exclusively catching babies at home, that we don't have any medical knowledge, that we don't have prescriptive authority, that we are essentially working outside of the system, and that we are inferior to obstetrician gynecologists. And the thing that's kind of magical though about midwifery is that our outcomes are better. They're so much better. Like our birth weights are better, our breastfeeding rates are better, people making it to term are better, people's overall health care is better, but that's a real threat in the system that we have right now, because it is hierarchical, it is capitalistic, and we have for-profit healthcare. So what that means is that in a lot of systems, midwives aren't the ones that are the decision makers. And that's sad, because I think our outcomes, if you look at, the United States and health disparity and what all that looks like, they would be markedly better if midwives were the ones that were providing care like they do in Europe or Australia or wherever it is that midwives, everywhere else but here, where it's the norm. And so I think that that's like one piece that I wish people understood my job a little, so that they can see like the work that I do, because I feel seen in like the niche that I'm in, right? Because I have plenty of midwife friends, I work with midwives, like fine. But in the larger context of things, like even like my own mom, when I was pregnant with twins, would ask me like, when are you seeing the doctor? And like, mind you, I did collaborative care because twins are higher risk, but I had to help her change her language and say, you mean, when am I going to the midwife office, Mom? Like, and you have to, I think we have to work hard to do the work. And the work is that, again, like we help people take care of themselves. And we also have privileges, like I mentioned, like prescriptive authority, et cetera, that help get people what they need, like birth control and abortions and safe deliveries and breast pumps and, whatever. So that's a big challenge. And then the other thing is I don't understand, like a lot of people think of reproductive justice and they just think about abortion care. And that's so limiting because there's so, I mean, I mean, I think that people should have access to abortions on demand without apology, like, period. However, like, if you look at the larger context, reproductive justice actually means that people are fed, that people have education, that people have access to birth control, that people, you know, are safe in their communities. Like, all of those things are reproductive justice. And I think that that's, especially from like a white cis lens, they're like, oh, so you know, give money to Planned Parenthood or whatever. It's like, no, that's not at all what this is. So I think that those two things, you know, like, and you know, I think being seen and then also understanding the larger context of what reproductive justice is would be helpful to help us all do our jobs a little bit better and care for people safer. So.
Thanks everyone for answering. I think that you all bring up really important points. In the new reality of COVID-19, here we are. Amalia, can you take over answering this, asking?
Yeah, of course. So I think it was a good transition. Well, one, I just want to say, I think, as Logan said, you all bring up excellent points, and it's really just, I've been to so many feminist events that say when it's a struggle for one, it's a struggle for all. So it's really bringing in this holistic scope of, like, not only is it abortion, not only is it baby care, it's access to housing, it's anti-racist, anti-oppressive structures. It's like really having conversations. And so I just really appreciated each of you bringing that point to life. So just to transition into COVID, as it is so important, just wondering how your work has changed during COVID. More specifically, how has the importance of and/or need of your work changed in our new reality? And potentially moving forward, what practices that may have emerged in response to COVID do you think are worth carrying forward with us? And if there are any, can you share an example with us? And I'll drop this in the chat as well.
Oh, good old COVID. It has definitely highlighted things that we have been advocating for a while that we know have been very necessary and helpful. So telehealth has been amped up at the University of Chicago. We actually have a hybrid model of care now that we utilize that incorporates with telehealth visits that we kind of strategically made, specifically, you know, starting off care at 12 weeks and, you know, having that in-person visit around that time with ultrasounds. And then every 4 weeks, as you would normally go through, you rotate through a telehealth and then an in-person, limiting everybody's exposure to the hospital because we're not sure, you know, in this early stage of the COVID situation, if we're exposing people, how we're exposing people, mask, no mask, you know, all that stuff. So we wanted to limit everybody's time coming through the hospital. So we devised that with patients definitely having to come in person towards the end there. And so, you know, patients appreciated that. One, because they were homeschooling their kids or, you know, were at home and not working. And so they may not have had means to, you know, transport themselves to the facility. And so it allowed them to not be stressed about transportation and finances and all that stuff, especially if they were not working. But we had been saying for a while that telehealth was something that we should have been incorporating a while, and we just kind of got thrown into it because we needed it. And so that is one thing that I would say we would keep, and we are keeping it at the university. We, especially with the Midwifery group. And so that has changed how we care for our patients. The downside of the whole situation has been that our patients' support that they have already been comfortable with and were known to bring with them, they cannot do that. especially in the outpatient setting. Now they can do that when they go into labor, and we do have doulas that come into the hospital, so we have advocated for that. And one support person being their partner or whoever else they desire. But to them, you know, to not be able to have their partner who they are sharing this pregnancy with and not be able to come in and listen to the heart tones and talk about planning and their involvement further cuts out the partner who may have already felt left out because for whatever reason. And so that's been very challenging. But if they have a telehealth, that person can, you know, their partner can be involved there. Nonetheless, they're not hearing the heart tones when they're at home. So, you know, there's that disconnect there, and trying to make sure we, you know, are very mindful of our pregnant patients' support system and how we can make sure they're still comfortable through their pregnancy and allowing them to have the support that they have. So that has definitely been a challenge. We are continuing to work to see how we can better our practices. Of course, as you know, individuals get vaccinated and the mask mandate, things are getting, restrictions are getting looser and looser, but we are being mindful that we don't know what's going to happen in the fall, and we're kind of just staying consistent with the things we already have in place, and we'll continue with that until, if we get hit again, and we're prepared for that. So that's how that has changed. There has been, though, patients that don't want to come to the hospital at all. And so what we will notice are the hospitals have closed. Mercy is slated to close. St. Bernard has closed their labor and delivery unit. Trinity had closed their labor and delivery unit for a while because of COVID, and they had decided to care for COVID patients. So prioritizing one patient for another is just very disheartening, because I feel like families start with pregnancy and reproductive care, and to negate that and, you know, place less value on that, just shows you again how flawed our system is. And so, you know, that has been very disappointing, but, you know, we're out here trying to advocate and make sure we have other birth options for patients, with the birth center and home birth. And so we just need it all. You never know what's going to happen in the future, and we want to make sure we have all the options. The patients can make a decision on where they want to go or don't want to go. And so hopefully, unfortunately, as devastating as this pandemic has, it's what they call that blessing in disguise, where things are going to change, but it should have changed a long time ago. It shouldn't have cost us 400,000 lives.
I can talk. So one thing that's changed a great deal is that I look like an astronaut when I'm catching babies, which is annoying for lots of reasons, but also just weird. Like I pre-pandemic would wear a pair of scrubs and some sterile gloves, and that was it. And we do water birth at our practice. And so trying to catch a baby in the water when you're wearing an N95, a face shield, a gown, gloves, booties, and whatever is very hard. So I think that it's been for me, and also I came out of, like, COVID happened 2 weeks after I came back from maternity leave. So for me, it was really hard because I was breastfeeding my twins, and trying to work, and trying to figure out whether or not I was contaminating my breast milk when I was coming to and from the hospital and to and from, you know, the office was really challenging. And, you know, navigating how to, you know, like Karie had said this, like how to feed my family. Like I wasn't going to not be a midwife anymore, but I was called to show up in a way that I had never, I didn't have a choice in the matter in a way, and I wouldn't have changed it, but like nobody, like you just had to keep going to work, and had to keep like helping people and catching their babies and giving them birth control and what have you. So, you know, it's been exhausting. I think that the lack of PPE was very real for me. We were using garbage bags at our hospital when there weren't gowns. reusing N95s, like you're never supposed to reuse them. You're actually supposed to dispose of them after each use. And so we would have to wear them for 3 shifts and then hopefully get new ones. I was actually given an N95 by my hospital that had one of the valves in it. And they said to wear that with a surgical mask over it. And I'm like, okay, well, I'm protected, but I'm not protecting my patient. So this makes no sense. And it's like, you know, the access to equipment and all of that is really hard. And, you know, one of the things that's really nice about where I work is that I work at a small community hospital. And so we only do about 1,200 deliveries a year. If you compare that to like Northwestern, they do 12 to 14,000. So and I don't do 1,200 in my practice. Our practice does about 250 to 300. But it's a much smaller volume, and like 40% of the births are midwives, 40% are family practice doctors, and then about 20% are obstetricians. And so that's really different, that model. Family practice docs are very community centered. Midwives are very community centered. So the culture of our hospital is one that has been supportive, and our nurse educator has made a point to always have doulas. Those have been taken away from different hospitals, depending on the system, who's in charge, what have you. And so a lot of folks have come to our practice because you can bring your doula. And our visitor policy has always been partner and doula, and we've still gotten to do water birth, which other hospitals haven't done. And so I feel really lucky in that we were really well supported in maintaining our standard of care, which is to have, you know, in our practice, we want people to have whatever birth it is they want to have. So for some folks, that means an unmedicated water birth. And for other people, that means an induction and an epidural. So it kind of runs the gamut, but either way, we didn't have our sort of privileges taken away. So that was helpful. But I think, you know, I think that Karie kind of hit the nail on the head in terms of telemedicine. Like we also have integrated telehealth into our office, and it's been a lot safer and a lot more helpful, because right now in our practice, partners can come to 3 visits. They can come to the first, if it's a pregnancy, they can come to the first visit, an ultrasound visit, and our birth plan visit, but other visits they can't come to. And they can be there on FaceTime or the phone, which is nice, but it's not, obviously not the same. And kids can't come. And so for folks that don't have childcare, you know, it's impossible sometimes for them to come in because kids aren't allowed. And obviously, the more people, if you look at volume, the more people you have in the office, the more risk to the staff and the other patients if they potentially have COVID. So it's really tricky because we want to be family centered, but at the same time, we need to protect ourselves. And, you know, as I mentioned earlier, there was a lot of turnover in my practice. And so that was really hard because there were a lot of folks that chose for their own, you know, own personal reasons because they have kids and wanted to be closer to home, not to continue to catch babies with us. And that meant that we needed to find new people. And then that also meant that I needed to train new people because we hired new midwives. And it's hard to become a midwife. It is hard if you do full scope practice to teach people how to midwife. And it's hard to teach people how to midwife in a pandemic. One of the most valuable things I learned at DePaul was that like it makes sense for you to sit in a circle and share food, you know, or tea or coffee or whatever with people. And like part of what feminism is gathering. And it's very hard to foster that kind of community cohesion when you're in a pandemic. You have to wear a mask. Like it's, you know, safety, but at the same time, at what cost? So I think that people are hurting, you know, mental health issues are really, anxiety and depression is, you know, astronomical. I prescribe a lot of Zoloft for pregnant and nursing, lactating people, because that's what's we have the most studies on. Like, it's just trying to midwife people through this pandemic has been something. Myself, others, friends, patients, colleagues, new grads. It's been nothing short of very challenging. I feel lucky because I have 2 tiny little joy buckets that, you know, stole my heart a while ago. So that helps. But but damn, it's been something. So I feel like on like if I'm looking at like a bell curve of where we are, like, I think because people are getting vaccinated, we're like just here, but it's going to take a long time to be sort of new normal. So, yeah.
Yeah, I recently saw a meme, which is really how I get most of my news right now, that showed like a person who's doing a flip into the pool and misses the edge of the pool by like this much, and the writing on it is, "This is how close I came to quitting healthcare during COVID," and that resonated super hard for me. It's been just such a journey. And as I said, I started my first job as a midwife here about right before the pandemic started. So working for an FQHC, a community health center, through this pandemic has been very illuminating in a lot of ways. Saw very quickly what leadership and administration prioritized, which is, surprise, surprise, money, not healthcare personnel, not patients, not outcomes. So that's horrifying, but not necessarily surprising. And our clinic, I work in like just west of Englewood, and then I work in La Villita. So two areas that have been super hard hit by this pandemic, and so we see really high risk patients, and we were very, very, very slow to adopt any changes to our schedule, to PPE provision, and it's at the beginning of this, about a year ago, things were really, really scary. And I think for patients as well, but I was really, really struck by how, when I would ask patients how they felt about what was going on in the world right now, that this was just another emergency in their lives that have constant emergencies. So this, it has exacerbated a lot of things for a lot of folks, but COVID for the patients that I see was not a priority, and protecting themselves or their families from COVID, not a priority, when in order to survive, they needed to continue working and doing what they have to do. So, yeah, and then telehealth, I think, I agree 1,000,000% has been just a really wonderful way to increase access. And we, at our clinic, I hope will continue to be using telehealth a lot. It means that I can basically disrupt some of the steps behind getting treated for a yeast infection, which nobody should ever have to go to the health provider to do. I want to sprinkle metronidazole in the water essentially at this point. I'm sort of kidding, but not really. And telehealth just makes it so much more accessible. I can listen to what my patient has to tell me about what their body is doing, and I can say, okay, go pick up this prescription, as long as it's within a decent scope of practice. So I think that will really change for our patients eventually. I think I was really concerned, people were really concerned about access to things like abortion and birth control and pregnancy care near the beginning of the pandemic. And it's turned out that, at least for the folks that I'm seeing, that's not such an issue. Because now we can prescribe over the phone, we can call people, meet them over the phone. None of my patients use video. which is a bummer in some ways and like really nice in other ways. I don't know if you can tell, but I'm 38 weeks pregnant, and I will admit I do some of my telehealth visits from a bathtub. I call it my office hours. But I think it's just, yeah, a change in access. And I think it's really a good thing, like we knew we needed. Yeah, I think, I'm trying to think if there's something else that I wanted to say, but I forget it. But yeah, it will be so interesting to see how through the summer, as the city lightens up on some of its mandates and restrictions, what changes for our patients. Centering, we had started our first group right before the pandemic started. So I'm working super hard and excitedly to get that back in action for a group of people who really, really would benefit from and enjoy it, I think. But yeah, to what you're saying about community, I think this has really just changed what it means to be pregnant and to be a person of the body.
Thank you all for sharing your such holistic views on like healthcare and accessibility and community. Oh, we have more questions even. Hey guys, can you take your volume down just a little bit? Sorry. I'm trying to do this because I put so much work into it. Thank you for bearing with my children. Laura, I know you asked a question in the chat earlier. I didn't know if you wanted to read that. You wanted to read that aloud, or if you wanted us to.
Sure. It's several. Let me type in the chat again so I can read it again, or maybe it's not going to do that. Okay, so I will read it out loud. So I'm curious because I live with MS, and my daughter now is 10, and one of my research interests is feminist disability studies, so, and also reproductive justice. So I'm curious if Karie, Hannah, and Missy have, read this again, have ever worked with pregnant women who are disabled or chronically ill, and if so, how has that informed their care and application of reproductive justice?
I can speak to that a little bit. I mean, it's so midwife scope of practice varies depending on what your collaborating physician relationship looks like and also what your institution looks like. So I think that it depends. It depends on what the disability is. So I have not in particular worked with patients with MS, but I have worked with patients with chronic illnesses. And usually what happens is that I provide their, and I'm thinking about pregnant people, but, you know, also people that need, you know, well care. We usually collaborate with whatever specialist it is that they have. And so, you know, pregnancy, you know, is both complicated and uncomplicated. It's physiologic, but at the same time, our whole job is to figure out if you are if there's some other red flag that needs to be addressed as you're moving along. And so we're very well attuned at like seeing those red flags and addressing them. So I think that I think that part of the issue, at least for me, in providing feminist care is just trying to navigate all the systems. Like I work in an independent practice, but what that means is I'm not connected to a higher institution. So for instance, if like I'm connected to West Suburban Hospital, but it's a small community hospital. It's not an academic medical institution. So if I have somebody, for instance, with like a thyroid issue, we have our own like people that we like who are endocrinologists, but I'm not going to say, oh, hey, go to like, you know, the 6th floor and go see this person. Like I have to connect them very individually. And so that's a difference in our practice that's good and bad. The good news is we get to pick who we refer to. The bad news is access to care wise, these people are like, well, what do you mean you don't have just some, like all of these specialists sort of at your fingertips? So it makes the onus is on us to create those lists and create those referral sources. But you know, sometimes people come to us with complicated things and where they're not well connected. And I think that what's hardest too is sometimes people are risked out of our care for different reasons, and we would love, they should have midwifery care, right? Like it should be like a collaboration, because people need to be listened to. They need to be, you know, the whole kind of nursing model of care and seeing somebody as a whole human being. Like everybody needs that all the time, but depending on what the issue, like what the condition is, they might not be able to be considered low risk. So I don't know if that exactly answers, but that's kind of where, if we can, we have a very flexible collaborating physician who trusts our care too. So we can, you know, work with them.
At the university, it's a little bit different because we are in the hospital and we have our practice in conjunction with the obstetrician and gynecology department there. We do have access to those specialists. So our practice very rarely gets, a small portion of our patients are low risk. We get a low risk patient, we are excited. But when, you know, the beauty of our practice, again, midwifery, it spans, you know, we can do a lot of things. And so because we're within the hospital, we can care for patients with MS, and we can care for patients with thyroid issues and other, you know, disabilities. They will see the doctor, they will see the high-risk doctor, and the high-risk doctor will say, you know, this is what needs to be done. It's okay to go back to the midwives for your labor management. And so they will treat them for their conditions that we don't normally care for, but will just, you know, guide us on how we should treat if we need to get some lab work or we need to get some other tests ordered and stuff like that. We just do that. And so it's a nice model of care that I don't think we highlight enough, because midwifery care can be very vital in this environment. And like Missy said, everyone deserves a midwife. Everybody deserves a midwifery care. And just because you have a disability, you shouldn't be risked out. And so we are able to practice like that here at the University of Chicago, and our patients absolutely love it. And so, you know, yes, it has changed how midwifery care is provided. And it's just another aspect of what we do and how we can do it. But again, not a lot of people know that, and we're trying to highlight that. And again, people can choose that if they desire to have that type of care.
I don't think I have too much to add to that, besides, yes, that when I see people also, I would say a majority of my patients would be not considered like midwifery scope of care, a lot of chronic conditions, a lot as far as like pregnancy related conditions that make them higher risk. I collaborate very closely with an OB-GYN, and we do have specialists within our system, or within the hospital system. Sinai is where we send most of our folks. But that means that when I sit down with a patient, I can still say, and I say this, I think, like 900 times a day, like, you are the expert on your body and you are in charge of what happens to you. And you know, that doesn't change based on whatever medical conditions a person has. It's, you know, I like to compare it to like getting your hair done. Like, you wouldn't walk into a salon and be like, like, this is your choice, your body. And yeah, that's all.
Thank you all so much. I know that there was another question in the chat. Bonnie, would you like to share?
Sure. My question is just, what are the barriers to getting more Black, Indigenous, Latina, and Asian midwives out and practicing? Because what I'm seeing on the screen is not very melanated.
All right, I hear you on that one. So, I think, it's a couple of things. What we have to recognize is the history of midwifery and the true history of how midwifery came about. We also have to realize the racist environments that birth had evolved from. And so it started, with grand midwives and sometimes often called granny midwives. Slaves were midwives, taught to be midwives, and then they were kind of ousted and it turned into a more predominantly white profession. And so since then, we have not been able to diversify the midwifery practice due to a lot of barriers, and not just, racism, finances, and when you have a lot of factors that can play a role in preventing people of color from progressing and getting into fields as any other field, it makes it difficult. So we have to do a lot of groundwork as we often do, which can be exhausting. So just as we champion for reproductive rights, we have to champion for more midwives. And so that was my taking on when I noticed when I was in school too, how do we start with predominantly African-American midwives, and then now we barely have 6% of the profession in the United States is melanated. And predominantly the patients that we see are melanated individuals. So we have to change that. And the way we change that is admitting more of our melanated friends and family and colleagues into this community, supporting them emotionally, mentally, and financially, and making sure they learn the ropes and get supported when not only in school, but afterwards, we want to help them sustain. And so, which is why I did Melanated Midwives. I help students support them with scholarships, mentorships, and then make sure that once they graduate, they're also supported in their profession. And we just have to keep doing that. Somebody knows somebody that wants to be a midwife. Please support them.
Yeah, the other thing I would say about it too is that it's just so like now leadership, I think that part of again my issue with certified nurse midwifery is that it's centered in nursing, and nursing is very white. Like it is just, there are folks of color that are nurses, but the leadership positions are often held by white women. And it's something that I noticed, in terms of if you look at the College of Nursing at UIC, I think there's one faculty member of color out of, I don't even know how many, right? And so I think that part of it is the folks that hold the power in the rooms that admit students are not people of color. And so they don't prioritize admissions in that way. I think that, it was really disturbing. It's often disturbing, racism exists, but when I was really awakened to what the power dynamics were when there's a predominant practice of white midwives taking care of people of color, it's crazy. I had an experience as a student where a midwife who's white who worked in Inglewood wouldn't give a Black mom a breast pump because she said that she was going to sell it and not actually use it to breastfeed her baby. And it was so unbelievably offensive. And I reported it, it was a whole thing because I was that student that was hey, racist mother effer, what the hell are you doing right now? And I can do that though, because I'm white. right? So like I could say that and bring that to the table because of my own privilege. And so that's the part that's really, you know, wrong, is that my other, you know, cohort of students of color might have failed because that midwife could have gone to whomever and said, we're not going to pass them. Like, that's the thing that's hard, is like, you have to look at all of the smaller pieces that add up to what a degree in midwifery means, right? And so it's like, who's admitted to nursing school, who is ready to do the test, who can afford to do test prep, who actually passes the test, who's administering the test, who gets a job as a nurse, who gets the experience as the job as a nurse to then be hired as a midwife. What does it's like, it's all of these pieces that, and there's so many places where they stop, like there's a dead end for people that they don't get there. And it's crazy, but like, it's really real. Like if in 20, you know, whatever year that was, 16, it was 5 years ago, but this midwife thought that she had she did have the power to wield this over someone. That's what they do. It's what white women have been, a lot of white women have been conditioned to do. And so until that gets dismantled, like, you know, until like patriarchy and capitalism and like a top-down medical model and a for-profit healthcare system and all of that stuff changes, it comes from really tiny things, like giving people breast pumps whenever they want one, because through the Affordable Care Act, everyone is eligible for a breast pump. Like that. Thank you, Obama. Yay, right? You cannot so I think that there are little steps or really big ones, like Karie starting, you know, an organization for people of color to become midwives, so that the folks that come to seek her care, like, have providers that look like her. You know, like, I think that there's big things and little things, but the system is effed. Like, it's just really scary, which is why, again, I alluded to earlier, like, I would fill up my cup on the East Campus of UIC, and then it would get dumped out and lit on fire on the other campus, because the medical hierarchy is very white, very cis, not feminist. So.
Ditto.
All right, we did have one more question. Maybe we can just go through quickly. Does Dr. Mukherjee, would you like to share?
Sure, and I'll be quick. I know we're close to closing time. So I was just wondering, and first of all, thank you so much for sharing your experiences and journeys. I was just curious as to, I remember, I think Missy said, this is such, work that is disruptive. I kind of remember the word as you were describing your journey. And I was thinking, how do you find joy, compassion, and community within this kind of really flawed medical system within which you work?
I think, just having the joy of a client, patient seek you out, feel appreciated and heard when they have the experience that they desire from you, doing this work, and students that I have been awarded scholarships are just like over ecstatic about it. And so just, finding joy in that has allowed me to continue on, and knowing that there's the good outweighs the bad, and it keeps me going. Having a good community of friends and family, midwifery is small in Chicago. And so Missy and I stay in touch. A lot of our, classmates stay in touch. And so we really have a nice, solid network, we support each other in all our endeavors. And so that's been very helpful and important in keeping us going, at least keeping me going. And, you know, trying not to allow the negative and all the politics and all of the things that we see and experience just steal our joy, and knowing that, you know, we have a lot of work to do, and it will be beneficial, even though it may not seem like it at this point in time.
Yes, same for me, definitely. The interaction that I have with my patients, clients, really, on most days, not every day, makes a lot of the bullshit really worth it. I really love doing first pap smears for people and like helping make that positive, engaging, like patient-directed experience, because so many people come to us fully traumatized by the medical system already. And if I can give a good, ideally a decent first experience with gynecological care, that feels really, really wonderful to me. And I also have a very overly active text chain with people from my midwifery cohort. And that's so wonderful, supportive, helpful, terrifying sometimes, but yeah, even in like these COVID times where we're so separate, there is community in doing this very intense work, and that's amazing.
I agree with Karie, like the midwifery community is really small. And so I've actually really missed, like we usually do, more formally, we do 2 meetings a year where we do business and stuff for what's called the Illinois affiliate. But then informally, well, before COVID, we would get together. Myself and another midwife created, or kind of kept going, this like midwife social group, which is, she moved to Los Angeles. So I'm trying to figure out if we can revamp it. But like even just, being among people who do this work is really important, because it's wild. Like what we do, like we meet people where they are in a wildly, like just an unpredictable time. And you're sort of carrying, at least with birth work, you're carrying them through from one version of themselves to another. And it's raw and it's crazy. And, you hold that space. And I think that, I do a lot of yoga, or at least I try when my kids are sleeping or when I'm not I do yoga in the call room, a lot. That's a quiet space if I have like an induction or something and I can hang. So I try to do that. And I try to fill my cup that way. I'm lucky in that my practice, we do a midwife meeting every week. And so we spend 2 hours, we work as a team. So we share patients, and so we work together to create care plans for everybody every week. And that's really unique, but it's great because we can, sort of share the experience. It's via Zoom, and, everybody has feelings about Zoom, but at least we're still trying to keep that sort of community aspect moving. So and also I really like catching babies. Like it's really fun. So that brings me a great deal of joy, especially if it's somebody I've had. Now that I've been at my practice for 3.5 years, I have some repeat people. So I've caught a set of brothers or other people's kids, and it's really cool to be there, and to be that person for people, and to help carry them through the experience. So I think there's no shortage. Like I'm tired, right? Because I'm a midwife, I'm a mom of twins, we're in a pandemic, all the reasons, but I still get a lot of joy out of baby catching. And I think that some people decide never to do that, but for me, I think I always have to be doing that because that's what helps, fill my cup. So now that I say that, the birth gods are going to rain on me and I'll probably catch
You did it.
12 babies in March, and I've already I did it. So pray for me, to whatever God you pray to. But yeah, I don't know. I do love what I do, even though it's challenging and crazy. But then the last thing I'll say is, like, I was cared for by midwives collaboratively. So I know, and Karie was, and I assume, Hannah, that there's a midwife catching your baby probably. So, you get to actually feel and experience what you're doing. And I did that. Well, there were 17 people that were at my birth. Like, it was bananas. But my entire midwife practice was there. So I felt loved. So being able to spread that love and catch the joy and do all that is pretty awesome.
Thank you so much. And on that wonderful note, unfortunately, we're out of time, but thank you all so much, and particularly to our panelists, Missy, Karie, and Hannah. Thank you for joining us, sharing all your stories, journeys, joys, struggles. I've learned so much about the holistic notion of midwifery, so it's been a wonderful experience. I also would love to thank this collaborative effort by the WGS Graduate Colloquium Committee and Triota. I particularly would like to recognize Amalia and Logan for spearheading, leading, and chugging along in the midst of really busy quarter. I know everything that you all are doing and really appreciate your time and leadership, but also thanking Maya, Cassandra, Madison, Kendall, Gwen, Nina, and everyone else who made this event possible. Thank you to the Women's Center and the WGS department. Thank you, and take good care, everyone. See you soon.
Thank you so much. Just a wonderful, wonderful panel. Thank you.
Thank you, guys. It was awesome.
Thank you.
Take care. Thank you
so much.
Thank you, Karie. So good to
Of
meet you.
course,
Thank you, Missy.
of
Thank you.
course. See you later, Missy.
Karie,
Thank you all.
we should get together when it's
We do.
safe.
Really soon. Let me know.
Soon. Hannah, good luck with your birth.
Congratulations, Hannah.
Congrats. I didn't even notice you were pregnant, but
Yeah, ready to be done any minute.
Where are you delivering?
Swedish.
Oh, cool. Awesome.
Nice.
Yeah, I did my clinical training there as well. So it's like, and my first child was delivered there as well.
Like coming home. I get it.
Exactly. Yeah.
All right.
So great to meet you all.
Take care.
Good to meet you, Hannah. Bye.
Bye-bye.
You have a
Bye.
birthday today.
Bye.
You're gonna have a birthday today.
I just wanted to say thank you.
Of course. You're gonna have
Also, congratulations